Welcome to Hibbert Health. I have Dr. Peter McCullough joining me today. Dr. McCullough, thank you so much for being here with me. I really appreciate you joining me. You have a lot to contribute, and I'm really looking forward to talking with you.
Thanks for having me.
My pleasure. Dr. McCullough is an internist and a cardiologist. He's the vice chairman of medicine at Baylor University Medical Centre in Dallas, Texas. Dr. McCullough is very broadly published, is an editor of 2 major journals. And Dr. McCullough, please tell us what got you involved and got you so active in the COVID-19 research.
Well, again, thanks for having me. And let me state that the opinions I'll express are those of my own and not necessarily those of my institutions, and don't reflect the opinions of Baylor. You know, I'm a chronic disease researcher. I'm an internist and cardiologist. I focus on the interface between heart and kidney disease. I have a degree in epidemiology. And I largely have just been focused on chronic diseases. And when the COVID-19 pandemic really came on like a storm and swept across North America, I viewed it in a sense as my personal and professional Super Bowl. It just got delivered right in front of us. It was a medical problem of unbelievable catastrophic proportions. We knew nothing about it. And so I stopped my research, turned on a dime, and directed all my focus on COVID-19.
I can understand that. So can you tell us a little bit about the work that you've been doing on COVID-19 and just how it's affected you professionally, as you described a little bit already, and personally?
Mm-hmm. Well, I mean, personally, unfortunately, we had tragedies in our families. We had a death of a young woman on my wife's side of the family. My father, who's in a senior home, contracted COVID and had a very prolonged course. Ultimately, my wife and myself had it. So as with so many people, COVID's affected us personally. We've had one mortality in our family. And if anything doesn't excite us to move on a problem, that should be one of them. And when we started looking at this in March, I was on our task forces and other things locally. I fortunately had great collaborations with friends in Italy from prior research collaborations. So we started watching what was going on in Milan metro area and reached out to the Italians through what's called the Coracle Network, and quickly formed a very large multi-center prospective cohort. And we published a whole series of papers on various aspects of the pandemic, including mortality according to levels of respiratory care needed. We broke the story on the protective effect of chronic use of ACE inhibitors, mortality. We published greatly on thrombosis, even have a risk prediction scheme for thrombosis of interest. The CHADS VAS score, which we use for thrombosis for stroke and atrial fibrillation, works pretty well for this illness. And so I have to tell you, by about April, May timeframe, we in the United States with our Italian collaborators began to have an idea that, in fact, we understood 3 major phases of the illness: viral replication, cytokine storm, and thrombosis. And it was based upon those principles that we organized to produce the first published treatment algorithm for early ambulatory COVID-19. And that was submitted early in the summer of 2020 and was accepted in the American Journal of Medicine in August 7th, 2020 and published.
Can you tell us a little bit about it?
Well, the principles were based on the idea that there were some available anti-infective agents that in preclinical studies and then in clinical studies had a reasonable chance of success in terms of reducing viral replication and had acceptable safety profiles that they could actually be used clinically. We followed this along. We recognized that some were studying prophylaxis, that is, could a drug be given to prevent the initial clinical infection? But we were much more interested in the acute treatment, what could be done. And once it became known that with more and more testing, that an average patient, when they test positive with COVID-19, is typically sick for about 2 weeks before they come in the hospital. That means we have a 2-week opportunity to do something. And we operated on the principle that probably doing something in that 2 weeks would beat doing nothing. So something's better than nothing. So if anything, our logic would rely on that some type of connection between the care team and the patient would be better than no care. particularly with in older individuals and seniors with medical problems, the anxiety of having a progressively more severe viral infection that creates shortness of breath and difficulty breathing to the point of requiring hospitalization is enormously anxiety provoking. And in a paradigm where doctors do not treat patients and they don't pick up the calls, where guidelines say don't treat patients at home, the anxiety among older patients who get this potentially fatal illness is through the roof.
This feeds into your 4 pillars for pandemic response for COVID-19, no doubt. Would you like to go into more detail about that?
Yes, well, I've published on this and presented on this that in my view, a virus like this that gives a 2-week lead time to do something clearly can be applied what's called the 4 pillars of pandemic response. So the first pillar is contagion control. So it's a highly contagious virus. So all these efforts to wear masks and socially distance and quarantine at home and all these efforts, hand sanitizer, it's all on contagion control. That is slow the spread of the infection. Mm-hmm. But because it's so contagious and because we're so far into this, with all the effort on that first pillar, it's obvious that it hasn't snuffed out the infection. And even in places where there are almost no cases of infection, as soon as we let up on any of these measures, the infection comes right back. So it doesn't get extinguished. So there's nothing to suggest that contagion control extinguishes the infection. Should we do it? For sure. I mean, do I wear a mask every day? I've been doing it for months. Do we use hand sanitizer? You betcha. But the bottom line is, with such a massive public health effort on contagion control, I think we've taken the eye off the ball, the second pillar. The second pillar is early home treatment. And the goal of early home treatment would be to reduce the rates of hospitalization and death by lessening the intensity and severity of symptoms. Pillar number 3 would be the hospital itself. Well, in the United States, our hospitals right now are at the highest census of all time. We have all the latest and greatest technology. We've had a great deal of confusion and disagreement on almost all the in-hospital treatments, including remdesivir, convalescent plasma, various forms of antibodies, early or later mechanical ventilation. It doesn't matter because the in-hospital mortality rate is still about 5 to 7% in U.S. hospitals. Those who require oxygen at the highest level of respiratory care is 12%. Those who need mechanical ventilation, 25%. So my point is, when we have in America, we have 260,000 deaths, which is more than any war in history. The hospital is obviously not an adequate safety net. It's just clear. It's not safe enough to say, listen, let's forego all medical interventions to hospital. Not in my judgment. Now, the 4th pillar would be vaccination or herd immunity. That is, to close out the infection, everybody becomes sufficiently immune that if someone has the infection, they just can't give it to somebody else. As we're looking at the pandemic in the United States, it looks like there probably will be more natural immunity than vaccination-mediated immunity. By the time the vaccine is ready to close out the pandemic, it will be a minority of the population that truly will need it. Probably more than a minority will be vaccinated, but vaccination should close out the pandemic. But the point is, with all the efforts on contagion control, all the efforts in the hospital, and we hear a lot about vaccines, we virtually hear nothing about early home treatment, early ambulatory treatment, virtually nothing. And we've had no conclusive randomized trials. There's not a single government with all the resources available to them that's put together a convincing prospective randomized clinical trial done as an outpatient. None. And that would be with single agents. And we know that with any serious viral infection, that we always need multiple drugs for acute viral infections, including acute HIV, 3 or 4 or 5 drugs. Even herpes zoster, we use valacyclovir and prednisone early on. So we never treat viruses with single agents, never. So a randomized trial scheme where we're testing one drug after another is simply not the right approach. It's not going to be responsive enough. And in fact, governments basically gave up on this early in the pandemic. So we're really left with using imperfect sources of data to try to piece together an emergency response for home treatment.
Now, isn't early treatment for any kind of illness or infection a cornerstone for medical care? So I don't understand why the focus is not on that at this point in time. Can you elaborate on that a little bit or discuss that a little bit with me?
Well, at no time during the pandemic despite our recognizing that this is a potentially fatal infection, by any medical organization or by any guidelines body or any governmental health response agency, did any one of these stakeholders utilize the principle of early treatment to reduce the intensity and severity of a disease? None. So when historians look back on this, they'll say, wait a minute, don't we have time to antibiotic administration for community-acquired pneumonias? Don't we treat urinary tract infections early, or staphylococcal infections, endocarditis? The answer is yes, 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 yes. Oh, but wait a minute, for this infection, no, we will not treat this early. And it's permeated through Infectious Disease Guidelines of America, National Institutes of Health, World Health Organization. It's really been extraordinary. All the early treatment trials were basically stopped early. The National Institutes of Health had a very simple trial in May and June, prospective randomized trial, 2,000 patients. They gave up after 20 cases. World Health Organization did the same thing. There are some trials that are underway. They're clearly on the slow track. We have favipiravir in the United States on the slow track. We have colchicine out of Montreal Heart Institute on a slow track. These are on clinical trial recruitment courses that we would for chronic disease. They're going to finish it in 2 to 4 years and write it up. But it's not, there's no behavior like we're in the middle of an emergency. And if we would have put all our resources on an outpatient sequence multi-drug approach, which I'm going to present here, if we could have done that in March, April, May timeframe, we'd have this thing done. The trial, we had all the resources at our disposal. I mean, if we can do a 60,000 person vaccine trial, we sure as heck can do a 1 week or 10-day drug trial.
There's no arguing that. Now, there's a lot of countries, though, that have home care. And do you want to talk about that a little bit?
Well, it's so interesting. So the other really interesting thing is about the pandemic response on treatment. I would argue in the hospitals are they're all basically about the same anywhere in the world. They're trying to do all the best they can. I would argue contagion control, the masks are all about the same, and maybe some countries are more stringent than others. Mm-hmm. Then, of course, the vaccines are global. So what does that leave? The second pillar again. So you can ask, what are countries doing for early treatment? And it's so interesting. There are countries like, let's say Canada, UK, and Australia, strictly no early home treatment, strictly nothing, not a milligram of treatment, none. United States, it's kind of blended. The doctors, United States is a very individualistic country. Doctors have strong personalities. And despite United States guidelines that say do not treat, National Institutes of Guidelines do not treat, there's always a little paragraph that says, but it's still up to the doctor's judgment. So as an example, so you have these countries. So I would say some countries in South America, United States, Canada, UK, Western EU, and Australia, where there is it's either non-existent or very poor or inhibited home treatment response. You have other countries where it's wide open. In 30 countries, they are distributing sequence multi-drug kits with hydroxychloroquine, ivermectin, antibiotics, steroids in 30 countries. You can look at what Japan does. Japan actually had a drug, favipiravir, that was fully approved for influenza, but it works on the RNA-dependent polymerase, the same target that remdesivir works for, favipiravir. So the Japanese use favipiravir, but they bring people in the hospital to use it, which is kind of interesting. When you look at the data, it looks like they could just treat them at home, but they're cautious. You have Russia that just brought in favipiravir. India brought in favipiravir. India was already using hydroxychloroquine. You have ivermectin, which is a broad-based antiparasitic, as a base of the program in Bangladesh, very densely populated area. Greece has hydroxychloroquine first line. So how can you have a guidelines in Greece? I mean, all of us probably been to Athens. It's a first world place where in Athens, you would go through a protocol and you'd have hydroxychloroquine plus another antibiotic and then sequence with the other drugs. And that's first line treatment. But then you go in the United States and it's, in a sense, almost prohibited. So the pandemic response itself, I think, to an acute, potentially fatal problem couldn't be any more different across the world. And anytime there's variation in practice, it's always something to be studied from an academic perspective. Variation from practice is always a signal to look at treatment patterns. And it's also an opportunity to look at best practices. So if how we manage this infection early at home was uniform across the world, we wouldn't have too much to talk about, honestly. But because it's so different, we should ask the next question is, well, let's look at some best practices and see what people have found.
Yeah, absolutely. So what have we learned at a high level about COVID-19 pathophysiology?
Well, the virus is an RNA virus. It enters the cells in the upper respiratory tract through the ACE2 receptor, which is interesting. That's its target. ACE2 receptor is markedly upregulated chronically by ACE inhibitors. One of the reasons why ACE inhibitors are somewhat protective. And once the virus gains access to the system, it not only invades all the different lines of white blood cells, but the liver, the heart, the kidneys. It's been found in urine. It's been found in stool. The virus has actually been found in the myocardium. Mm-hmm. So it's clearly a systemic infection. It triggers immune dysregulation characterized by a depressed white blood cell count initially, a high C-reactive protein, and then very interestingly, in this interface of creating endothelial damage and cytokine storm, it trips off the coagulation system. And so microthrombosis was described by the Italians, where it explained why the chest x-ray pattern, which showed these characteristic COVID pneumonia, but it wasn't a severe pattern, why it would be out of proportion to the desaturation. And it explained that it was actually due to microthrombosis in the lungs. Since that time, there's been multiple cases of very large thrombi throughout the body. And so we have a great respect for this virus. Some viruses, by the way, caused hemolysis, right? Mm-hmm. But this virus causes thrombosis. It uniquely causes thrombosis. And in my view, that's probably the most feared complication of this virus. Of the cases that I'm aware of where the outcome has been, they've survived, been catastrophic, it's been thrombosis. The cases that I'm aware of that have been fatal, almost in every case, thrombosis has played a role.
Amazing. And massive organ damage. For people that are surviving this.
I'll just say one more point about the thrombosis to hammer this home.
Please do.
Is that we are finding in other conditions where patients happen to have COVID, that it's greatly complicating them. We published a paper about acute myocardial infarction treated with stenting, where the rates of acute stent thrombosis are typically less than 1%. And in our analysis that was published in the American Journal of Cardiology, the rate of stent thrombosis in a COVID patient who's also having an ST segment elevation MI is 20%. It's 20-fold higher. So it is stunning, this thrombotic component to it. And so I've made the case that, boy, we don't want to be waiting 2 or 3 weeks into this. And you know how it is with thrombosis. It's so much easier to prevent it than to begin to treat thrombosis. So the treatment principles involve early on, if possible, reducing viral replication, and then secondly, addressing cytokine storm and thrombosis.
Would you like to share some of the experiences you're having treating COVID patients? Because I'm sure you've seen hundreds of COVID patients at this point in time.
Well, out of the gate, I think I had one of the very first investigational drug applications for hydroxychloroquine, an anti-malarial. I think the date of issue was March 26, 2020, where we embarked on a prophylactic study of our healthcare workers. That study has still not reported its final results because of administrative delays that were imposed on the study. But we did have, I believe, 225 patients under study at that time, and collected information about healthcare worker exposures and emergent infections. But since that time, in my clinical practice, I estimate that I've treated somewhere between 100 and 200 patients now who've developed COVID-19, all through telemedicine. And the approach I've followed is the one that we published originally in the American Journal of Medicine. And the principles are as follows. Patients under age 50, in almost every published study, when they're healthy, really don't require any treatment. The illness is self-limited. You can always almost set your clock on it at age 50. And so to this day, if I get a call from somebody in their 40s, worried about it, no other medical problems, don't have severe symptoms, my advice is always no treatment is warranted. So I do concur with treatment guidelines from the Infectious Disease Society of America and from the National Institutes of Health for that population, age under 50, no medical problems, no severe symptoms, no treatment. And that's actually a big segment of the population.
Yeah.
Now, where my concern is over age 50, and then we start adding on medical problems, that mortality begins to be 1, 2, 3%. I'll give you an example. I'm age 57. I have asthma and atherosclerotic cardiovascular disease. My mortality is probably closer to about 4%. Now, if you take my life and you fast forward now to age 80, now that mortality can be closer to 50%, and the composite of death and hospitalization is closer to 40%. So these mathematical relationships are very well worked out, and they're highly age dependent.
When patients are given their positive test results, why is there no NIH Research Hotline provided?
Well, many would view that in the heat of fear and panic and isolation and everyone working from home and all the government agencies trying to be responsive, I think historians will look back on this whole thing and recognize some strategic blunders. You can imagine that we clearly have the most fatal illness in the history of our country. And our current approach, as it probably is in your country, is that patients are literally handed a test result from a testing center, urgent care clinic, and they're saying, you're positive, go home. There's not a single piece of advice given. There's no hotline to call to get into research studies. Patients go home and they literally try to figure out the next steps. Like, what do I do? And is it possible to navigate clinicaltrials.gov and find out about research and get into a research protocol? Yes. United States, as of a month ago, thankfully, one physician organization stepped forward, the American College of Physicians and Surgeons. They now have a home treatment guide. And the home treatment guide starts to mention some reasonable steps to do, including isolation, ventilation in the house, contact tracing, etc. And then as of a month ago, there was a home treatment guide published by the American Association of Physicians and Surgeons that is a very useful resource for when patients get their positive test. They can go home, and this is available electronically and can be printed out, where it outlines the next steps regarding self-quarantine, how to ventilate the house, do contact tracing, sterilize surfaces in the house, etc., to reduce the viral re-inoculation. And then it goes through steps based on evidence of what can be done, what's reasonable in the home that has a reasonable chance of success and adequate safety. And it does involve the use of some over-the-counter vitamins and micronutrients. And so all of these actually have some data behind them and are viewed as being largely harmless. And first one is zinc sulfate. Zinc sulfate in other trials of other coronaviruses reduces the duration of symptoms. That's been proven in randomized trials. And zinc plays a pathophysiologic role once it's intracellular to begin to inhibit viral replication. It is believed to be synergistic with one of the off-target antivirals that I'll mention in a minute. Now, the second supplement is vitamin D3, and the epidemiologic data show that patients who are vitamin D deficient have much higher rates of hospitalization and death. And there's been one randomized trial from Israel demonstrating reduced mortality from vitamin D supplementation versus placebo. Small trial, but still randomized clinical trial. The next supplement is vitamin C, almost based on principle in terms of general URIs, 3,000 milligrams a day is suggested. And then the fourth one that's come along is an antioxidant called quercetin. And this is given at 1,000 milligrams a day. I know little about it outside of it being a cellular protectant. So there's this kind of simple layer of things that can be done that falls in the category of couldn't harm, maybe it could help. I don't think anybody thinks these are curative in any way. I think a lot of patients have gotten the word. Their cabinets are stacked with these right now. Now, in the home treatment guide, the next step, though, is age over 50 is to start combination anti-infectives. Now, the anti-infectives serve two purposes. In preclinical studies and in clinical studies, they reduce viral replication, the duration of viral shedding, and they have supportive data in reducing the clinical outcomes of hospitalization and death. And they include hydroxychloroquine plus azithromycin or doxycycline. Now, hydroxychloroquine is an antimalarial. It impairs endosomal transfer of the virus and is also anti-inflammatory. And we are now up to, I believe, over 100 peer-reviewed published studies. And in fact, they come pouring in every day, randomized trials and observational studies that show together a 64% relative risk reduction for death and hospitalization when started early as an outpatient. The calculated odds that hydroxychloroquine does not work are 1 in 17 billion currently because the massive studies is so great. People have said, well, wait a minute, the only thing that counts is randomized trials of a single drug. Well, in a meta-analysis that I am an author on with others that is under review at the British Medical Journal right now, just the randomized trials and just hydroxychloroquine alone is associated with a 24% relative risk reduction for new COVID-19 infection when used prophylactically or for death and hospitalization. So in my view, it's relatively clear hydroxychloroquine as a base would play a role. Now, why would we add azithromycin or doxycycline? They also have a mild intracellular effect in impairing the viral replication, but they would cover superimposed bacterial infections. There are now papers showing about a 2 to 3% overlap between mycoplasma, concurrent mycoplasma, and also chlamydia pneumonia. And I personally have had a case where it's an overlap, and I'm really glad I had the antibiotic there where they test positive. The second base anti-infective option would be ivermectin. Ivermectin is a broad-based antiparasitic drug. It can be given, a typical dose is 200 micrograms per kilogram, so it comes out to about 12 milligrams as a single dose. And the real question there is, in about 5 observational studies and 4 randomized trials, the real question is, for how long do you do that? My current guidance on this is 1 dose every other day for 3 doses. So that would span it over a course of about 6 days. Half-life on that's about 18 hours or so. Ivermectin, again, plus one of the antibiotics I mentioned. And then in 30 countries and featured in Japan and Russia and elsewhere is favipiravir. Favipiravir is an oral RNA-dependent polymerase inhibitor, has the same mechanism of action of remdesivir. It's used for influenza in Japan. So it's used in a sense as a Tamiflu, if you will, for COVID-19. And that drug has a very favorable side effect profile. And in many ways, I wish that drug was available worldwide. And there are some efforts to have that undertaken. And I have firsthand communication and knowledge, and it is also publicly known that there is our first patient in the United States as of tonight receiving favipiravir in one of our major hospitals as that patient's, in a sense, right to try. We have a law in the United States called right to try, meaning that if one invokes that law, the patient can't be denied therapy. So we know that's happening. But that anti-infective box, if you will, the first layer, boy, we ought to get going on that in the first day. And we don't want to be a week or 14 days into it. The virus replicates in an exponentially increasing fashion over the first few days. Patients just at that time typically have some nasal congestion, some injected conjunctiva, mild fever. They may have some mild shortness of breath, typically not a prominent sore throat, loss of taste and smell, general, what I call viral malaise. That would be the typical first 3 days. But by day 5, or if there's any pulmonary symptoms that set in, the pulmonary symptoms are interesting. They are cough, but there's like a unique sense of just inability to breathe or get a satisfactory breath. And I personally had this, so I can report to you firsthand. It's an odd sense of breathlessness, and I had to test myself up and down the stairs a little bit. That middle phase there, we think, is what's called cytokine storm. In the published studies, and we've published on this, there, the C-reactive protein is very high. Interleukin-6, if you measure, it's very high. And interestingly, a thrombotic marker is high, the D-dimer. And this has been well described. D-dimer is elevated. And what could be going on concurrently with cytokine storm with this idea of endothelial injury of the virus and immune system dysregulation is thrombosis. And so this cytokine storm phase can be treated with steroids. We have data from the recovery trial in the UK, not blinded, prospective randomized, not blinded, no drug accountability, all the flaws of a rushed trial, but they chose an odd dose of dexamethasone, 6 milligrams PO or IM, but it was associated with a statistically significant reduction in mortality, not a huge reduction, but a statistically significant mortality. But in the treated group, the mortality rate was still 23%. So I've always made the case, listen, if they're applying it there and it's 23%, we need to do better than that. There are now good data from Brazil suggesting we can use prednisone, which is a common steroid we use, and typically day 5 or any pulmonary symptoms. But the key is not too early and not too high of a dose. I think 1 milligram per kilogram is what we said, probably no more than that. That means for an average person, maybe 40 milligrams of prednisone for 5 days with or without a taper. We also know in that cytokine box can also be the use of colchicine. Colchicine inhibits microtubule formation in granulocytes. And in the Montreal Heart Institute's doing a wonderful trial called the Cold Corona trial. I'm personally a subject in it, and it was wonderful. I did it all over the phone. I did the consent over the phone, and the study drug was delivered to my house when I was in isolation within 2 hours. It's a spectacular trial, spectacular. And that's colchicine versus placebo in that trial. But one clinically, if you couldn't get access to the trial, certainly could prescribe it. And then concurrently with this, when we get to the point of steroids, the doctor ought to be thinking about thrombosis. We have plenty of data now, all highly, highly concordant, that when patients are clearly having thrombotic events, and when antithrombotic agents are utilized, there is a massive reduction in mortality, 50% or more. It's very stunning in very large observational studies. You may ask, where's the randomized trials? We're way late on them. The NIH has a trial of aspirin, way late. There's a trial using rivaroxaban, way late. Bottom line is, I don't think we'll ever know, and nobody feels comfortable not anticoagulating. Our nephrologists learned very early on the dialysis tubes were clogging in these patients. They used very aggressive anticoagulation systems. We've seen catastrophic strokes, stent thrombosis. It's the type of thing we can't wait for a clinical trial. In my view, if I've learned anything about this virus, is that chronic disease models of clinical trials don't have the emergency framework that we need. What we really need is doctors to be able to put together the pathophysiologic concepts guided by available clinical data and bring a program to the bedside. And that's what I did with the group, the Italians. We published it in the American Journal of Medicine. We became the featured approach in the American Association of Physicians and Surgeons Treatment Guide. And this is moving forward. Certainly across the United States, what we're seeing is very interesting. I saw the data from the CDC today. We're having a massive surge of COVID-19. The hospitals are full, but they're not yet overflowing, although I've predicted they'll overflow. But they may not overflow because doctors have organized into these treatment networks, and we have 24-hour hotlines and all different types of availability. And so as the message gets out to patients that this problem can be treated at home, I think the patients will drive a lot of it. There's not a single person I know in their 70s with heart and lung disease that wants to sit at home for 2 weeks on the guidance of to do nothing. There's nobody who accepts that. I haven't had a single patient say, doctor, I know the guidelines, or my doctor says no treatment. I'm just fine sitting here and just waiting to go to the hospital. Nobody says that. Nobody in the right mind would say that. And as a doctor, I personally think it's unconscionable to abandon our patients. So what do? I use supplements and 2 off-target antivirals. I get those going. Minimum duration of treatment, 5 days. Maximum can be 30 days. Then I phase in steroids if needed. And then I layer with antithrombotics. Aspirin, 325 milligrams a day for sure. There are good data from UCLA showing that this virus markedly elevates thromboxane A2, probably blows away 81 milligrams of aspirin. We need 325, but I don't hesitate for a minute to use low molecular weight heparin. If I have a patient in a nursing home or senior home, or use the oral anticoagulants. The one I've been using is apixaban, but I could have used rivaroxaban or dabigatran. The bottom line is aggressive treatment of thrombosis, typically for about 30 days. So what can this multi-drug sequenced program do? Well, I can tell you, someone at my age in their 50s, if I faced a composite of hospitalization death of 7% in all the published series so far, that can be reduced to under 1%. So it's very impressive. In the elderly group, where death and hospitalization is 40%, that can be reduced to about 3%. So home treatment has a massive impact on the treated natural history of COVID-19. And I'll stand behind that. People say, oh, you don't have all the randomized trials. I said, because I didn't have all the money up front. Decisions were made elsewhere. But there isn't a single trial today that is yet to be designed with the sequence multi-drug approach that I just presented. It doesn't exist. So if anybody wants a randomized trial of what my group put together, it doesn't exist right now. So I think this is one for the history books, where it's based on clinical judgment, intuition, synthesizing the pathophysiology, And people have challenged me and said, well, wait a minute. What if a new monoclonal antibody comes on board? I said, terrific. We just had bamlanivimab approved in the United States. I said, bring it on. Monoclonal antibody as an antiviral. President Trump received this. Wonderful. We could use it in nursing homes where it could be administered right there. We could use it in emergency departments where patients receive their point of first diagnosis. By the way, most patients nowadays are diagnosed in testing centers or urgent cares. And once patients go at home, one of the advantages of treating at home is we don't have patients going to the hospital and panicking, going to urgent cares, contaminating things. So I don't think administering the antibody at home is going to be feasible because healthcare workers are going to have to come into the home where it's highly infectious environment and then risk themselves because we don't have negative pressure ventilation. We don't have all the other, PPE to protect the healthcare workers. And we don't want the patients breaking isolation to go to some infusion center or go to the ER. So I think the antibodies, what I've positioned them for is nursing home use, stocked in nursing homes and in ERs. Terrific. Monoclonal antibodies would fit right in. If there's a new oral drug, favipiravir, or there's one in phase 2 trials, if it was advanced, and we had a new drug to replace hydroxychloroquine or ivermectin or favipiravir, bring it on. If we had, for instance, a Japanese product, I'm positioned to be the overall principal investigator on Rematroban globally. If we get Rematroban going, Rematroban is approved in Japan for allergic rhinitis, but it uniquely also has an antithrombotic capability. It looks like it'd be perfect for COVID-19. If we get one of the antithrombotics, terrific. But I do think the principles of sequenced multi-drug treatment, which is what we're doing in the hospital anyway. When patients go to the hospital, these principles are used. I think advancing these principles into the home is, in my view, the only practical option on the table to reduce the risk of hospitalization and death until we get to broad-scale vaccination.
Now, the home treatment guides and even just the basic guides that someone can get over the counter, is that accessible to the public?
Yeah, if the public wants to access the American College of Physicians and Surgeons website, the home patient guide is available to them. In the back in the appendix are these links to various treatment sites and treatment centers that have broad prescribing capabilities. Unfortunately, through telemedicine, patients can get their care. And that may be going on right now. I think there are more community physicians who are starting to get comfortable with the sequence multi-drug approach. And I know that I'm working very closely with the network of doctors who are doing this. And the nice thing about telemedicine is they can have quite a scale. They could actually work across the entire country and take care of patients. And I know it's going on today.
Yeah.
How I've summarized it, I think the people who are actually being hurt the most are the very young. So we have children where the mothers are now, full-time teachers and trying to do homeschooling and what have you, and trying to keep their jobs, and young people losing their jobs. And then the very old. Obviously, the very old have taken a tremendous mortality hit. If people in senior homes have survived COVID, now they're in, individual room confinement. And both of my parents are right now in solitary confinement in 2 different rooms in a senior home. And it's complete torture for them. They can't see their family members. They can't see each other. But I do worry about kids and children where the arc of their life is being altered. And it's clear the seniors in some of their, last few years left, they're being robbed. They're being robbed of family relationships, the old and the young. And I think these segments of the society, we'll never forget it. We didn't live through World War I or World War II, and I barely remember the Vietnam War. We just haven't had strife. But we're going to remember COVID-19 for a long, long time.
Yes, it's definitely changed all our lives. Thank you so much, Dr. McCullough, for joining me in this very interesting and very important discussion. I really appreciate the time you spent with me. And for everybody out there that might be listening to this, please subscribe to my YouTube channel so you can see new videos as they get uploaded. And I hope to bring more good information forward, just like we have this evening. Thank you.